Mary. I'm the Pharmacy Oncology Service Line Manager. I've been here at UW Health for 17 years now, and I've been an oncology pharmacist for about 36 years. So as I tell my pharmacy residents, I was around before Zofran, if you can imagine such a time. Today I wanted to talk about chemotherapy safety and chemotherapy policies. I know this is quite the exciting topics, but I think really important to discuss. Here's our objectives for today. So just to kind of bring you back to med school or nursing school, a medication error is any error that occurs in the medication use process. And as you're likely aware, the medication use process can be anywhere from patient and drug information to drug labeling to prescribing, staff competency, patient education. So it can really be a pretty broad area. So how do medication errors happen? We spend a lot of time as the leadership team and my clinical pharmacists that work in the oncology space in figuring out how we can prevent errors. So what systems can we put in place to prevent errors? The thing is, like, humans will make errors. So we just try to put in these layers of Swiss cheese as such to try to prevent the errors from reaching the patient. So obviously more layers are better. There are some holes due to active failures and then other holes in the Swiss cheese just due to conditions that may be occurring. I'm sure you've all seen this. So in oncology pharmacy, it might be computerized physician order entry, standard core treatment plans that we use for the treatment of cancer, chemo competency, so making sure nurses, pharmacists, the fellows and APPs are competent before, verifying, prescribing, administering chemo, and then in a system of independent double checks to, again, try to catch those errors. Unfortunately, sometimes the holes can line up and can lead to an error actually reaching the patient. There is no perfectly safe system. No matter what we do, there will be ways for things to reach the patient. So we have to try our best to follow policy, to use the safety standards that are there to prevent this from happening. So the FDA receives more than 100,000 reports every year of medication errors, and more than 7 million patients in the United States are impacted by medication errors every year. And 10%, this is all an estimate, of hospital patients will be subject to some type of a medication error. So cancer patients, which is why we're talking about this, are at an increased risk of harm. Their physiological reserves could be compromised by the nature of the disease and the effects on vital organs, immune function, and functional status. Many antineoplastic therapies are toxic with narrow therapeutic indices. I often tell people that there aren't a lot of areas of therapeutics where you give doses of drugs like methotrexate that are intended to kill people, and then rescue them. So it's very different from normal, like, antihypertensives. Therapies may include novel agents or combinations that require multiple dose adjustments and precise monitoring of laboratory parameters. So chemo errors can range from incomplete orders to life-threatening errors. There's not a lot of publications on this, but chemotherapy errors probably occur at a rate of about 2%, which seems like a lot to me. they affect 1 to 3% of adult and pediatric oncology patients. And again, they can occur at all stages of the medication use process. Oral chemotherapy use is a particular area of growing risk. There's problems with access to patient-specific information by outside pharmacies. We're lucky here. We have a mail order pharmacy and outpatient pharmacies that are part of UW Health that do have access to needed patient-specific information. But if it goes to an outside specialty pharmacy or a Walgreens, they're not going to have this. And the amount of medication taken per dose, or not as a total daily dose, to be divided. So you can, the way you prescribe oral chemo and the way we talk about dosing for oral chemo and other chemotherapy can be confusing to people. So these are ISMP, ISMP is the Institute for Safe Medication Practices. So it's actually a national agency that is not for profit that looks how to decrease patient harm and prevent errors where they can. So every year, every 2 years, really, the next one won't come out till 2026. They release their best practices for safety. And for oncology, these were the ones that were related in this last group. Dispense vincristine and other vinca alkaloids in a mini bag of a compatible solution and not in a syringe. So as I would ask my residents, why is this? So we used to give vincristine as an IV push. It's usually a 2 milligram dose for an adult and 2 milliliters. Unfortunately, it's often given, especially in pediatric patients, but also in adult leukemia patients at the same time as or on the same days that they're also getting intrathecal chemo. So if you give vinca alkaloids intrathecally, the patient, it's fatal. The patient will die. And that did happen here not that long ago, about 24 years ago. And when I came here 17 years ago, we were still dispensing it in a syringe. Now, of course, we dispense them. We comply with this particular recommendation. Use a weekly dosage regimen default for oral methotrexate in electronic systems when medication orders are entered. This is because for oral methotrexate for like rheumatology indications, it's usually weekly. So we default that to weekly for just regular medication orders for our inpatient system and for outpatients. For adults, we do change that in treatment plans where we can do it safely. Weigh each patient as soon as possible on admission and during each appropriate outpatient encounter. Avoid use of stated, estimated, or historical weight. This, of course, is really important in oncology treatment. Administer all med and hydration infusions via programmable infusion pump, utilizing dose error reduction systems. We have smart pumps here that have hard maxes and sometimes soft minimums so that the dose for the patient is right. The medication administration record in Epic talks to the pump. So the nurses can scan the medication and automatically program the pump with the information in that system. So it's a very smart and safe system. Ensure all appropriate antidotes, reversal agents, and rescue agents are readily available. When you start thinking about it, there are a lot of these in oncology. So if you have an anthracycline extravasation, you need to make sure you have dexamethasone on site. Glucarpidase for high-dose methotrexate. We have a rescue agent for 5-FU overdose. And then the last one is to eliminate injectable promethazine from formulary. We've extremely rarely used promethazine anymore in oncology, and we do have injectable promethazine on formulary, but it's hard to order, and we put it in a mini bag to prevent extravasation. So I always like to tell these stories. This is when I was kind of a young oncology pharmacist. And these next two events, I think, are what really solidified my interest in medication safety. And this particular one, the Dana-Farber story, I think is what changed the way we prescribed chemotherapy. So Betsy Lehman, who was a Boston Globe health columnist, and Maureen Bateman, a teacher, and this was when we used to do autologous transplants for breast cancer. They both were breast cancer patients, were prescribed and received 4 times the intended dose of cyclophosphamide. So instead of prescribing the daily dose to be given on each of the 4 days of the cycle, the combined 4-day dose was given on each day. This was written by a fellow at Dana-Farber, but it went through numerous medical staff, including attendings who double-checked the orders. 25 medical staff were involved, and not one noticed the problem until weeks later. And it was actually a research coordinator who was recording this in the patient's record. So Betsy Lehman died as a result of the error. She didn't die. They were able to support her through the various cytopenias. She actually died of cardiac damage, which is seen with high-dose cyclophosphamide. And Maureen Bateman suffered permanent heart damage and subsequently died of her original cancer several months later. As we're all likely aware, it really doesn't work till you do autotransplants for breast cancer. So in this research study, they had said, I think it was like cyclophosphamide, the correct dose was 1,000 milligrams per square meter of body surface area each day for a total of 4 days. So instead, they gave 4,000 milligrams per meter squared, which was the total 4-day dose each day for 4 days. So obviously a well-respected institute who had highly trained people doing this work, pharmacists, nurses, fellows, attending providers, and yet this went through. So we changed the way at that point we prescribed chemotherapy and how we wrote orders. This one I think is very sad. It's from a little bit more recently, from 2009. This is called the Rainbow Baby story. So this pharmacist actually went to jail over this. So it was a little 3-year-old child, and she was being treated with chemotherapy. So this was like her last treatment. The treatment was done, and the family was looking forward to going to Disney World the next day. Unfortunately, through various like holes in the Swiss cheese, so the computer system had been down overnight. So when it went back up the next morning, all these labels printed out. The pharmacy ran out of normal saline, so they had to prep normal saline. And this was like the big problem. They were very busy. The nurses really wanted to get this child out of there on time, so called down and gave an earlier time than what the patient was actually due to receive the chemotherapy. And she, what happened was, due to this rushing around, due to inattention, due to just human error, they used straight 23.4% sodium chloride and put the etoposide in that. So the poor child died in agony 3 days after receiving this intravenous solution, which of course caused her brain to retain everything. So they basically indicted the pharmacist on charges of reckless homicide and involuntary manslaughter. The pharmacist spent time in prison, which is not the right thing in a just culture. The technician was fired immediately. So it was a terrible thing. The good thing that came out of it is the father of Emily started a patient safety organization, which he still runs, this foundation. They work closely with ISMP, the Institute for Safe Medication Practices. So, and they actually, he went to see this pharmacist while he was in prison, and they kind of became good friends, actually, or at least felt a lot of sympathy for each other. And they now speak together. If you ever get a chance, it's really quite a good thing to listen to. So sources of error in electronic prescribing. We know that electronic prescribing is a lot safer than the old way of writing orders. However, I call it video game prescribing, where we're not paying attention, we're trying to get the task done. We can have incorrect data entry. I've seen wrong weights. I've seen pounds of patients put in as kilograms or opposite. The design of the system, using workflows outside of the electronic build to try to get things done again. If you guys have tried to look up treatment plan options in Epic, it's pretty confusing. Failure to acknowledge or to think about electronic alerts. And then some risk factors for severe prescribing errors. So we know risk factors are orders with more than 2 chemotherapy drugs, which we know happens a lot. When you have occasional users of the electronic prescribing system that maybe don't do that as often, and junior physicians as they're learning. High-dose methotrexate has been a problem here. We had 4 serious medication errors since 2010, with 2 ICU stays and 1 acute kidney injury. This led us to do a lot of quality improvement work with nursing and physician leadership. Mike Fallon, leading this course, did a ton of work on the high-dose methotrexate clinical practice guideline. The way we do high-dose methotrexate here now is very safe. There's a lot of things that go into this to prevent patients from being harmed. And I think this is a really good example of quality improvement work and of looking at errors and trying to figure out how to make things better. As fellows and as APPs, you will get a chance to participate in this work. So we've already talked a little bit about this, but UW Health has addressed that intrathecal chemotherapy safety. So we have a chemotherapy policy for intrathecal chemotherapy that describes what agents can be used. We do know that inadvertent intrathecal administration of drugs such as vincristine and bortezomib is still reported in the literature. So we do routinely prepare all vinca alkaloids now in 25 ml piggyback bags. And we know that it presents a struggle for balance between prevention of fatal errors versus the risk of non-fatal but severe adverse drug events such as extravasations. Vincristine is very harmful when it extravasates. And then any intrathecal administration of a drug must be preceded by a timeout where you make sure it's the right patient, the right drug, the right route. So some prescriber challenges we've had is that new practitioners or trainees may not learn how to write chemotherapy orders due to an overdependence on technology. So we have changed our training process and quality assurance to try to make sure that our fellows and our APPs, as they're learning to prescribe chemotherapy, understand how to order it and what the different factors are that go into it. One thing that we noticed is that people don't learn doses of drugs as much, and we don't know if that's because, the physical task of writing does help you cement that in your mind versus just clicking buttons to sign orders. I think we see that then as a tendency to view as a task to complete rather than as a tool to safely prescribe chemotherapy. Another problem that can be seen in electronic prescribing of chemotherapy is copy and paste issues within that treatment plan. So moving on to how do we report medication events? So We do have a just culture here. We don't blame people for human errors. That's not to say you wouldn't be held responsible if you knowingly went against policy and did something you knew would harm the patient. But I think that's very, very rare. No one that's in medicine goes into medicine to hurt patients. So we use a system called the HERO system. HERO stands for Healthcare Event Reporting Online. So the goal is to report medication errors, adverse drug reactions, near misses, and risky situations in order to improve patient care, also to help with education of professional staff, and then to comply with accreditation standards. It is a way to gather information and develop solutions. At 8:30, I go to a meeting that we have every week where we look at serious safety events from the previous week. It's mostly physicians, nursing leadership, and then I'm the pharmacy representative. We also have representatives from lab, from materials management, from other areas that need to discuss these events. And it's a transparent means of discussing safety solutions for our institution and a forum for identifying opportunities. It is not punitive. We support just culture, and it's a venue to discuss topics outside of safety-related issues also. It is not that. So what happens with this reported information if you fill these out? And this morning I reviewed all the events from yesterday, and there were several filled out by physicians. So each event is evaluated by quality, risk management, physician, pharmacy, and nursing. These are medication-related events. Queries are made into finding the reason behind the event. We assign a harm score. System sources of the error are analyzed, and any necessary changes are implemented, and the data is collected and presented. So this is just how to enter a new event into HERO. If you go to the Pulse, the front page has a direct link to HERO. So I'm sure Mike sends these slides out, but this tells you how to quickly and rather efficiently enter a new event into HERO system. And it is important to report these events that happen so that we can look at our systems and see if we need to make changes. Now, on to chemotherapy-related policies, and just for awareness. So this is our big policy, policy 6.1.1. We call it our chemo policy. It is under review right now. So we're kind of finishing up the latest reviews, and then this will come to like the faculty meeting and to fellows and to nurses with any updates. But this policy is a good one to review and at least know what's in there. So know what, if you need to look something up, where to find it. It covers a lot of things. It covers informed consent for chemotherapy, how to order it, how to verify it, administration, documentation, and patient and family education. So this policy covers prescribing of chemo for both oncologic and non-oncologic indications. And when you go, if you look up this policy on the Pulse, there's a bunch of related appendices that have information in it related to chemotherapy. We also have, as I already talked about, an intrathecal chemotherapy policy. To be, I guess, transparent, this will eventually be wrapped up into the regular chemotherapy policy. We felt that having a separate standalone intrathecal chemo policy wasn't necessary anymore, and that it might be easier for people if they were all in the same policy. But this one is still in effect, and just to, I just wanted to make sure you guys were aware of it. So an intrathecal chemo policy, and this will all be transferred over to the big chemo policy. It talks about what can be prescribed intrathecally, who can prescribe it, and how it is administered. That's the end of my slides. Does anyone have any questions or comments? As our quiet group and no faces. If not, I will turn you over to my colleague, Jason. I'm always available. Most of the attendings have my cell phone number, but I'm available via email, or you can look me up in the Pulse directory and contact me via phone also. Jason, I'll turn it over to you.
Thanks, Mary. All right. Good morning. I'm going to cover the second portion here. Just flip this.
The slides look good, Jason.
Look good? Okay.
Yep.
We're kind of continuing the theme here from Mary, a little bit different lecture this morning. Again, trying to focus kind of more on policies, and then in my section, kind of some more practical workflows as it relates to oral oncolytics and prior authorizations that we had some feedback through the years that would be helpful to share in this series. So can briefly introduce myself, Jason Bergsbaken, another oncology pharmacist on the team here. I guess key areas that I'm involved with on the team that I'll talk about today. The first one is Chemotherapy Council, which is our oncology P&T committee here at UW Health. So I'm going to be reviewing processes for that group. Currently serve as secretary of that committee. Throughout the years, have also been pretty involved with our oral oncolytic and prior authorization processes in conjunction with our specialty pharmacy team. So that will be another theme for my brief presentation this morning. So with that, I'll jump in. I don't see anyone on camera. I very much would welcome any comments as we go through here. I know a number of you have worked in this system already for a number of years. So if you have questions, feedback as it relates to these processes, please go ahead and interject as we go. So, all right, I'm going to start with, again, Chemotherapy Council. So Chemotherapy Council is kind of used synonymously at UW Health with Oncology P&T Committee. So you can see where we kind of lay. Our authority is really derived from the medical board, again, underneath our larger P&T umbrella with the other subcommittees. We're really viewed and relied on as the oncology experts within the organization. So with that, we've really tried to maintain a robust membership of providers, nurses, and pharmacists with hopefully kind of broad representation across the cancer center to carry out our aims. You can see our representation currently here on this slide. Again, we have a number of physicians that are on our group. We again try to have representation across our solid, our hematologic, our transplant areas, gyn-onc as well. We do have advanced practice provider representation as well, nursing, and then again some pharmacy members. We do have a couple of our regional sites that do participate with us in a non-voting capacity. So Pro Healthcare in the Milwaukee market, and then Gunderson, now Amplify in the La Crosse market, do join our group in a non-voting capacity, and we kind of share our recommendations with them. Again, from a leadership perspective, so Dr. Callender and Dr. Deming currently serve as our co-chairs and lead our committee. I serve in the secretary role. I reviewed that membership, I guess notably for the fellows that are on the call, and some of you, I believe, have already achieved this, but as part of our fellowship, our MedOnc fellows do rotate through the committee on a quarterly basis. During that experience, our fellows do serve as full voting members and kind of as a full member of the committee as part of your fellowship experience. You can see our aims here. So really our really first and foremost aim is safety, really to maintain the highest level of patient safety at our institution above all. I kind of like to reflect back on the origins of our committee. This is really before our time, or my time, but at the case, at that time, we unfortunately had an event where we had an off-label administration of cetuximab, which resulted in a adverse event and ultimately a patient passing. So I think at that time there was a lot of discussion around, a peer review process for a group to assess the evidence for, evidence and safety risk first benefits of our regimens, and particularly our patient-specific non-standard care cases, really to give our physicians, our providers, our groups, again, that peer review support and peer review process. So that was really the origin, and I think, patient safety continues to be at the forefront and top of everything we do. In addition to safety, we do have some other aims as well. So, really to have an evidence-based mechanism of peer review at the organization. Certainly as an NCCN center, we rely really heavily on, NCCN guidelines and of course FDA approvals, but really to understand, how these guideline or recommendations or approval recommendations, should best be incorporated within UW Health as a whole. And our committee leads that effort. Efficacy, of course, we look at as well. Uniformity and safety. So really trying to ensure that across our disease-oriented teams, as much as possible, we're doing things in a standardized fashion across the center as a whole. And then lastly is value. This was an aim that was added probably about 7 or 8 years ago. I think it's one that we continue to kind of weigh our role in, but as everyone's aware, our therapies continue to get of higher and higher costs. And I think at minimum, how we can empower teams to understand what some of the costs of these therapies are, and at least empower them to have some of these discussions around value as they discuss therapy options with their patients. So I'm going to pause there. Any questions, comments at all on kind of our membership or any of our aims? Okay, kind of how we do the work that we do and our responsibilities. So I'll refer you to another policy to be familiar with, policy 6.1.14. So you can search that in Pulse. This is our approval policy for core and patient-specific regimens in adult patients. And really outlines how we review standard of care requests, patient-specific requests, et cetera, throughout the cancer center. For transparency, Mary alluded to 6.1.1, which is undergoing revision. This policy is also due for revision. So that will be very soon getting completed and started. One of our goal efforts in this is to kind of broaden this a little bit. Right now, this has been very focused on adults within kind of the Madison practice. We're really aiming to try to incorporate some of the pediatric parts of our service line, which really right now kind of operate in parallel to us, and then also Northern Illinois, which also operates somewhat in parallel to us as a part of this next revision, just again so that we have kind of standard processes across kind of the entire enterprise for cancer care. So that will be coming, which we're excited to go forward on. If you do look at that policy, it will again talk about and outline some of our responsibilities, but kind of some of the things that do come to us in our monthly meetings. Any new chemotherapy formulary requests, so new FDA approvals or things that a provider or group would like to add to formulary would come to us and in scope. Core and patient-specific regimens, which I alluded to, and then any guideline revisions or policies, order sets, delegation protocols, really anything within kind of the medication use space as it relates to oncology care at UW Health, again, would be typically delegated to our committee to make a recommendation to P&T given the more robust oncology experts and membership that we have. If you do go to that policy, there's a couple of tables which kind of walk through procedurally how we kind of accomplish these responsibilities and aims. So these next couple of slides just go through kind of our core or standard of care process. Kind of at a high level to summarize this, essentially there's a request process that would come in from a provider and or team. Again, this could be a new agent to market, a new regimen, et cetera. The pharmacy team would kind of help in collaboration put together a standardized template that would then go to the committee for standard of care review. At the committee, there would be, again, an assessment based on those aims. After an approval, that would then coincide with kind of downstream operational steps, which include, a beacon protocol, any medication build in Epic, kind of stocking and all those things that, ultimately prepare us to deliver that new regimen for the patient. The other kind of process, so again, we recognize that, again, being an NCCN NCI center, we definitely see cases that we're going to want to be treating patients outside of what might be considered standard of care here at UW Health. So because of that, and again, the prior case that I alluded to, we do maintain a patient-specific process, which is really meant to serve as a peer review step for our physicians, our providers on therapy and delivering therapies outside of our UW Health standard of care. This is predominantly completed kind of via an asynchronous electronic review process within the committee. So kind of in summary, we have a standard form as well. Some of that you may have already been involved in this process. So that would come into the committee and that would be disseminated for kind of electronic review. Committee members would be, again, assessing safety, efficacy, and trying to help with that assessment. After we would have an approval, then that, again, similar to the core request, that would coincide with a build and kind of all the kind of operational steps to ready that protocol for the team to deliver to that patient. Just for reference, this process is utilized with some frequency. I would say for about the last 5 years, we've averaged somewhere in the neighborhood of 10 requests per month that have come through the center. I think we've tried to work with kind of the most recent policy revision and now this upcoming revision to try to identify, ways which we can continue to get those standard of care regimens available for teams, but again, preserve this process for the instances where we truly have, a patient-specific need and a peer review need to provide to teams. So that's kind of been the most recent direction of the committee. I'm going to pause again. A lot of information I went through somewhat quickly, but any questions about kind of our standard of care or patient-specific processes for those of you that have been involved? Would kind of welcome any feedback. All right, hearing none, I will keep going. I will direct you to the Pulse for kind of form. So if you search Chemo Council and Pulse, you'll kind of see as the top hits our core form, which is our standard of care form, our patient-specific form. You can always reach out to me as well. Sometimes I do kind of archive all the historical submissions. So sometimes if it's a repeat case, that could be kind of a shortcut for the team. So, by all means, feel free to reach out to me or one of the other pharmacy team members, and we'd be happy to help you. I did want to quickly comment on our triennial review process. So per policy, we do on an every 3-year basis review our standard of care library on a dot level, just to understand that these are continuing to be kind of contemporary recommendations, and then also assess for any opportunities as it relates to protocol improvement, standardization, et cetera. Helps us kind of abide by best practice with order set management in general. And then again, I think identify if we have, non-contemporary regimens that we're offering still in the standard of care library or anything we want to clean up for efficiency purposes. We kind of divide the dots out into, roughly third chunks. Our pharmacy team members have been very involved in that process and trying to help lead in conjunction with our providers that review. And then our Beacon team is also very involved. So we have about 7 clinical pharmacists that work on our Beacon protocols. So those are kind of the core team members. We've engaged nursing as well for input. So that's a really important process within the center, and I just wanted to highlight that. And you may be exposed to that within your dots that you're working with, or for the fellows potentially as part of your training. And then I did want to call out lastly, kind of important to this policy is our drug shortage management approach. So unfortunately, drug shortages continue to be something we grapple with in the cancer space. I think really the most recent review and revision was kind of spurned by our platinum shortage of specifically carboplatin cisplatin, which we managed a few years back. But we felt of historical value, and I think increasingly with these last couple of instances, it's been a refocused area, how important it is to have a policy and outline of how we go about approaching some of these shortages. So if you do, again, reference policy 611, which Mary mentioned earlier, there is an Appendix F to that policy, which really outlines how we go about this. In the case of the platinum most recent event, as an organization, unfortunately, we were to the point where we were, having to go to kind of a patient-specific level and understanding who our highest priority patients are in the organization. So certainly those are very difficult and honestly kind of unthinkable conversations, but I think having a construct has helped us kind of be organized in how we approach that. So we have essentially kind of 3 tiers of our approach. We would have surveillance, which is kind of our first tier, which is essentially where mainly the pharmacy team may be alerted that there's a product that may be on shortage, that we're kind of more closely surveilling the supply chain on. The second tier is more conservation. So kind of what efforts can we do maybe to defer to an alternate product if equivalent, or maybe there's, maybe rounding or scheduling steps we can do to kind of conserve the supply we have. And then that third and final tier is allocation. Again, we did get to this kind of in the platinum stage. This is where we would be, again, in engagement with our provider teams, trying to understand kind of how we should best utilize the product we have amongst current and future patients. So this policy was, again, approved in conjunction with risk management, legal ethics, and overseen by our P&T committee. So I think an interesting policy for you to note, and I'd encourage you to take a look at that appendix. Again, hopefully we don't have to use this in the near future, but I think it's been important to have it available to us throughout the years. So that kind of wraps my comments on P&T and Chemo Council. I'm going to pause another time before I jump into oral oncolytics if anyone has any comments, call-outs. All right, my next section is on oral oncolytics. Again, these are more kind of process comments, but through the years have felt valuable for this forum. Again, no surprise to anyone, but really over the last 15, 20 years, we've had this large explosion in terms of the market, in terms of available oral oncolytics to us, has created a lot of exciting new therapy options for patients. Those some new challenges in terms of how management has been transitioned a bit more to the patients, in terms of adherence and identification of adverse effects. So because of this, we've really stood up a lot of policies over the last number of years to hopefully provide best practice in terms of how we manage these patients. So our processes really have been driven by a lot of external best practices. So we've relied on ASCO-NS namely, but other ones as well, to really talk about kind of how we approach different aspects of the oral oncolytic process. So policy 611, again, Mary touched on, did want to comment on a couple of things. We do have Appendix A in that policy, which actually goes through and by agent, perpetually updated, defines what agents we define as chemotherapy here at UW Health. The reason that we've done this is really to be very crystal clear about what agents the policy umbrella applies to. So, for example, an agent like imatinib is defined on this list as chemotherapy. So all of these kind of further things I'll comment on policy-wise apply. An agent like tamoxifen, may be used in breast cancer patients, is not defined as chemotherapy. So tamoxifen is not required for informed consent and does not need a treatment plan, et cetera. So it's really meant to provide that definition for teams. We do, again, because of some of the risks, we really treat oral chemotherapy, oral oncolytics at the same level as kind of infusional. We want to really provide the same types of protections because while these are oral, again, some of the same types of safety risks apply. So that's been our overall approach at UW Health. A couple of key kind of requirements for oral oncolytics. So we do require informed consent here organizationally. So again, if the drug is oral, if it's on that policy Appendix A, it would be required in the same manner it would for kind of an infusional chemo plan. We do also require beacon treatment plans for oral oncolytics. We've thus far really used, I'll call it a hybrid model for prescribing. So what we've done to date is, again, if you're starting a patient on an oral oncolytic, you need to be applying that treatment plan, signing the treatment plan, releasing the med out of the plan, very much similar to what you would do with an infusional therapy. We recognize that kind of as patients go on these therapies, they're going to need to have kind of, maybe reordering and refills. We've kind of allowed that to date in a more of a hybrid approach, meaning as long as you have a plan applied and you're keeping up with kind of any required monitoring parameters, you could, out of the med activity, generate a refill. I would say as we move forward, particularly with kind of appointment requests, it seems like we are trying to move back into more of a treatment plan focused workflow. So that's been a bit of a work in progress, and I think at your clinic level you'll see that. But I think as we go forward, I would expect that we'll probably see less kind of refill activities out of the med activity and more in the plan, but kind of more to come on that. We do require dose modification notes. So I think, particularly for oral oncolytics, as these patients are on this at home, they may call in and not be seen in clinic with toxicity. If you're receiving that, you may give directions such as holding therapy, reducing therapy. So kind of to document that as a source of truth, we have a discrete dose modification note. There's a small snap here in HealthLink just to, again, create transparency. All of these note types do pull into a kind of our synopsis report. So again, it's very transparent for other providers, pharmacists, nurses, et cetera, to kind of understand what's the most kind of recent picture with that patient. For awareness, we do employ a prospective order review, prospective verification for oral oncolytics. So this is really done at the kind of department level. So we do maintain kind of a list of all of those agents that are defined as oral oncolytics here at UW Health. Within HealthLink, there's functionality where those agents, when ordered out of a cancer department, are hard stopped within a pharmacist queue. So pharmacists do perform a quote verification step before those orders are then transcribed, whether they be to a UW Health pharmacy or an outside pharmacy. Again, the concept of this was to try to put in place the same levels of safety and protection that we would have on, say, an infusional agent. So pharmacists will be checking, clinical information, but also checking, destination pharmacy, prior authorization, those types of things as well. So I think, it's helpful, when you're particularly in maybe the clinic setting, again, that communication between clinic teams and the pharmacist for kind of new oral chemotherapy starts is important. As I think that can kind of, again, just help kind of all of this be seamless in terms of getting these new orders generated. And then education, again, oral oncolytics, we do require that as well, similar to infusion therapies. Our pharmacy team members do lead the education efforts really across the enterprise related to oral chemotherapy, oral oncolytics. So again, just emphasizing to kind of get in touch with your pharmacist. We've really, I think, positioned pharmacists in this way, just mainly given our kind of touch points with our understanding of that the education needs, but also kind of, again, the prior authorization and kind of the distribution channels. So we're kind of that step that hopefully helps ultimately deliver that medication to that patient kind of in a well-educated way in collaboration with kind of our providers in the consent process. We do utilize a number of tools for education, for awareness. There is actually an external third party. I put the link there, pretty simple URL, orochemoedsheets.com. This is kind of a free external library. It's maintained by 4 pharmacy and nursing organizations. Does a really good job of being perpetually updated and meets all kind of the requirements of some of those best practice recommendations. So that's what we've really utilized here. I would say a lot of our peer centers have as well. So if you need to print kind of oral oncolytic teaching sheets for a patient, that would be a really good reference, and it's really user-friendly and searchable by agent as well. So, and then last comment before I kind of round out with the specialty comments is monitoring. So there is a recommendation by kind of many best practice groups to have some kind of ongoing monitoring approach as it relates to outreach, adherence, and toxicity. At this time, our specialty pharmacy does complete this for patients that are filling internally to UW Health. So I guess for all of your awareness, they kind of pharmacy technicians manage the refill process, but they do have pharmacists within their team that at least on an every 3-month basis, though they're working on kind of trying to increase those touch points, particularly early in courses for at-risk agents, do touch base with patients, and that's documented within HealthLink. On the clinic side, our pharmacists really try to do this as well, particularly for kind of higher risk patients. Kind of our full systemic approach has kind of waxed and waned through the years with our resources, but that is something that is on our radar as well. So I'm going to pause there. Any questions, comments, feedback at all on any of the oral oncolytic comments? All right. Apparently answering everyone's questions, so that's good. Last very brief piece here is just some brief comments on our specialty pharmacy program and prior authorization team and workflows. Again, I think just kind of practical information that would be helpful to know. So for awareness, we do have an internal specialty pharmacy program within our health system, or specialty mail service, or SMS. This pharmacy is physically located out in Middleton, kind of on the west side of town. You can see there off at Deming Way. And this facility houses our specialty pharmacy operation, as well as our prior authorization services and kind of a few other ancillary services within UW Health. So really designed and to be a mail order pharmacy. There is a ability for patients to pick up medications at this facility, and additionally, we have a medication kiosk, which is available right inside the doors that you see on that photo. So if patients do want to pick up during business hours, they're able to do that. After hours, we could set up the kiosk for them, but by and large, most patients utilize our free mail order service that we provide. Again, mail order is provided and preferred. It really depends on where patients are at. A lot of patients can receive next day service, particularly if they're in the immediate area. If they're kind of in an outlying area, it may be kind of an additional business day. I kind of touched on the management services that our pharmacy team provides as it relates to outreach and refill management. So just real briefly, again, that's where the pharmacy lives. And again, there's a really refocused effort within UW Health as a whole to try to maximize, all of our prescription capture, including, of course, our specialty medications. So certainly would, highly recommend them. And, we hope to be able to kind of service as many patients internally as we can as our insurances allow. And then finally, wanted to just briefly touch on our prior authorization team. So we do have a team within UW Health, kind of housed within the pharmacy department, that does all of the medication benefits investigation for the organization. Our current process is really driven by telephone encounters. So Our team members submit telephone encounters using a standardized dot phrase .onc PA to our teams. Within that team, they're essentially divided into a kind of pharmacy benefit or take-home group and a medical benefit or kind of in-clinic group. And basically by just routing it to our standard pool, they'll kind of take care of that piece. Everything is documented within HealthLink, within the referrals tab, to really give teams, again, the information you need to, how your patients are getting approved and where they can receive therapies. We do have our medication assistance program as well, and more recently have been partnering with our UW Financial Assistance as a whole. So again, if your patients do not have, say, adequate insurance coverage, we do have a full team that will look into eligibility for MAP programs or UW Financial Assistance. And then we do have a repository program now, both at our UH site, at our outpatient pharmacy, and also at our EMC site. So our repository program, if you're not familiar, is a way that it's actually a state allowed program where patients can actually donate eligible medications back that are kind of unused and unadulterated for then future patients to receive free of charge if they qualify. So really, really important program and program that's growing across the country. So another avenue in which we can help support patients that might not have kind of readily available insurance authorization. These are kind of just some things to think about, but again, I think just really the bottom is just being proactive. Again, our review process timeline will be really payer dependent. So I think as soon as we have an indication of what therapies you're looking to offer your patient, please work with your teams to get that submitted, so that our teams can start work on that and again, hopefully get you that information and documentation as soon as possible. So super brief comments on specialty and